Now, next question. We have a 47-year-old man who reports excessive daytime sleepiness, EDS, excessive daytime sleepiness, and difficulty maintaining sleep at night. Despite having a seemingly adequate amount of sleep, he often feels unrefreshed upon waking up. All these are classically symptoms of sleep disorder breathing. Okay, SDB, sleep disordered breathing. Different types of sleep disordered breathing are there. The clinical scenario which is being shown here is mainly pointing towards sleep apnea. Okay, so let us see what else are they giving. Okay, a polysomnography reveals intermittent cessation of breathing during sleep. So now polysomnography is the definitive test to confirm obstructive sleep apnea. So in polysomnography, intermittent cessation of breathing, basically what they are telling, apneic episodes are happening. Which of the following sleep disorder is most likely cause of this symptom? So we know it is a direct answer. It is obstructive sleep apnea, OSA, or simply sleep apnea, any of this option. So they've given 4 options here: insomnia, obstructive sleep apnea, narcolepsy, restless leg syndrome. So what is the answer here? The answer is obstructive sleep apnea. Now let us see a little bit about obstructive sleep apnea. When you have the description of the patient, sleep apnea is a disease which can be confirmed with the clinical signs and symptoms of the patient itself. So, what are the classical presentation of a patient with obstructive sleep apnea? Obesity, excessive daytime sleepiness, very cardinal feature of OSA. Because of the unrefreshing sleep at night, because of the multiple apneic episodes that happens during the night, the patient will have micro arousals. Because of that, even if they are sleeping for 8 hours, the next day morning when they wake up, they have an unrefreshed feeling, excessive daytime sleepiness, and polysomnography will show an apnea hypopnea index of more than 5. So here they've directly given intermittent cessation of breathing, that is apneic episodes are happening. Usually AHI, apneic hypopneic index of greater than 5 is diagnostic of obstructive sleep apnea. And then what is this polysomnography? Polysomnography is also called as sleep study. Polysomnography is also called as sleep study. Then what is an hypnogram? Hypnogram. Hypnogram, you would have seen something like this, no? So what is this? This is a hypnogram. Hypnogram is showing you the sleep cycle. Hypnogram only shows you the sleep cycle, that is different stages of sleep. Different stages of sleep is shown in a hypnogram. Then what is a polysomnography? Polysomnography is also called a sleep study. In polysomnography, along with the EEG, various other physiological parameters will also be recorded simultaneously over the entire night. Okay, and if they suspect obstructive sleep apnea, or if they have diagnosed obstructive sleep apnea in polysomnography, they will even do a CPAP titration in the same polysomnography setup. So that is called a sleep study. So what are all the physiological parameters that is recorded in a overnight sleep study or polysomnography? Most important is the EEG, that is the electroencephalogram. Along with the EEG, we will also record EOG, that is electrooculogram, EMG, activity of the muscle. We will check for oxygen saturation, snoring. Okay, another very important classical symptom in a patient of obstructive sleep apnea is snoring, history of snoring at night or history of snoring during sleep. Then chest and abdominal movements, ECG, okay, sometimes even blood pressure, nasal airflow. All these parameters will be seen in polysomnography. Okay, polysomnography is not merely an EEG. In polysomnography during sleep, so what is polysomnography? It is a technique in which during sleep, along with EEG, various other physiological parameters will be recorded simultaneously. That is called as polysomnography. Okay, so I think that makes you clear about OSA. In polysomnography, an apnea hypopnea index of greater than 5 is indicative of obstructive sleep apnea. Okay, so that is with polysomnography, hypnogram, and sleep apnea. Let us, since they have given other disorders like insomnia, narcolepsy, restless leg syndrome, all these are sleep disorders. Let us look a little bit into these disorders as well. What do we mean by insomnia? What do we mean by insomnia? Insomnia is nothing but a chronic ability to sleep in spite of adequate opportunity to do so. Okay, chronic inability to sleep. The patient will not be able to sleep, or to put it in simple words, the patient is not able to sleep. Inability to sleep is called as insomnia. Okay, then what is narcolepsy? This is a condition in which there is episodic sudden loss of muscle tone accompanied by irresistible urge to sleep. Muscle tone is completely gone and the patient wants to sleep. Irresistible urge to sleep. Okay, so since the muscle tone is completely lost here, immediately you can correlate and say that a patient of narcolepsy will start sleeping with REM. Okay, normally for others, normal person, the sleep will progress from awake, drowsiness, stage 1, 2, 3 of NREM sleep, then again stage 3, 2, 1, then only REM sleep will come. But in a person of narcolepsy, they will directly sleep in REM phase, okay, which is very characteristic. So when we do a sleep study, we will see REM sleep will, the patient with narcolepsy will have no sleep latency, and also immediately they will fall into the REM phase of sleep, okay. And also the hypothalamus of narcoleptic subjects contain less hypocretin producing neurons. Then, what is cataplexy? Cataplexy is a condition in which there is sudden loss of power of movement and posture while the subject is awake. Okay, followed by irresistible desire to sleep. Then, what is bruxism? Bruxism is nothing but teeth grinding, usually seen in children associated with dreams and REM sleep. Okay, then what is nocturnal enuresis? Bedwetting at night in children above 8 years of old. When does nocturnal enuresis become pathological? In children even beyond 5 to 8 years, if they still continue bedwetting, then only we call it as pathological. But for us, from physiology point of view, nocturnal enuresis means what? Bedwetting in the night. Okay. When we do EEG, it is usually seen just before an episode of bedwetting. A burst of rhythmic delta waves is seen in the EEG, and also there is generalized body movements. Then, what is nocturnal paroxysmal dystonia? This is nothing but choreoathetotic or ballistic movements are occurring during NREM sleep. So, that is called as nocturnal paroxysmal dystonia. Then sleep paralysis. Sleep paralysis is nothing, most of us would have experienced the sleep paralysis. It is normal. It usually occurs during the transition from sleeping to waking up state. During this phase, the patient is unable to activate their muscle, but they are awake, but they're unable, they feel completely paralyzed. Okay, it occurs towards the end of REM sleep. Then two important things: night terrors and nightmares. Night terrors usually is a childhood disorder occurs during NREM sleep. These are the key words I wanted to remember. That is why I didn't write much. Two words you have to remember. And night terror means it occurs in it's a childhood disorder. REM sleep disorder, NREM sleep disorder, slow wave sleep disorder. Nightmare. What do you mean by a nightmare? This is nightmares are more common in adults. It is a REM sleep disorder. Nightmares are REM sleep disorder in adults. Night terror is a childhood disorder. It occurs in children and it is an NREM sleep disorder. Okay. Then sleepwalking or somnambulism. Most commonly, somnambulism means sleepwalking. It most commonly occurs during NREM sleep. That is during the slow wave sleep or deep sleep. And patient is not aware of it on waking up. Okay. So that completes our discussion on various sleep disorders. Let's move on to the next question. We have a 45-year-old female with history of hypertension and diabetes. So she has both metabolic diseases, hypertension as well as diabetes. Now she is presenting with symptoms of headache, confusion, sudden onset of left-sided weakness. So the brain is involved. Headache is there, confusion is there, left-sided weakness is there. A neuroimaging reveals a contrast enhancing lesion in the brain. Whenever you see a contrast enhancing lesion in the brain, we all know the brain is protected by the blood brain barrier. Okay, so this blood brain barrier is going to limit the substances that is going to enter into the brain capillaries, into the blood. But now, whenever there is a lesion like this, whenever there is a tumor in the brain, or there is an inflammatory condition, there is an infection, some pathology that is going on in the brain tissue, in all these areas, the blood brain barrier will be compromised. When in the region of the tumor, or in the region where an inflammation is going on, there is an infection, all this will cause disruption of the blood brain barrier. So once in these region, when the blood brain barrier is disrupted, what is going to happen? You are giving a contrast. The dye will be taken up by that area that is disrupted. Easily the contrast is going to enter there. Because of the disruption of the blood brain barrier, the contrast will be taken up by the structure. That is why they do a neuroimaging. When they in the neuroimaging, they see a contrast enhancing lesion, means the contrast is taken up by that lesion. Why? Because the blood brain barrier is damaged. Look at the next line. Given the involvement of blood brain barrier in this case, now do you understand why blood brain barrier is involved in this case? Okay. Given the involvement of blood brain barrier in this case, which of the following statement best describes the role of blood brain barrier in context to brain pathology? So basically, they're asking the function of blood brain barrier. You have to identify that. So let us first, as always, revise our basics. Let us see what is this blood brain barrier, what is it made up of, what are the substances that is going to enter, and what are the substances that can leave through the blood brain barrier, and what are the functions of blood brain barrier. Okay, so blood brain barrier is mainly formed by tight junctions of the endothelial cells and food processes of the astrocytes. So what are the structures that forms the tight junction? Endothelial cells of the capillaries and food processes of the astrocytes forms this tight blood brain barrier. There are certain areas in the brain which is naturally devoid of this blood brain barrier, which normally do not have a blood brain barrier. Those structures are together collectively called as circumventricular organs. So what are circumventricular organs? Those are regions in the brain which is devoid or which does not have a blood brain barrier. So what are those areas? The median eminence of hypothalamus, the subpharyngeal organ, OVLT, organovasculosum of lamina terminalis, area postrema, that is the chemoreceptor trigger zone, and then posterior pituitary, that is a neurohypophysis. All these areas, 1, 2, 3, 4, 5. So all these 5 areas are regions very important for you to have to memorize and remember this, because these are called as circumventricular organs. These are regions where blood-brain barrier is absent. Okay. Now, what is this blood-brain barrier? As we just now saw, it's a selectively permeable barrier which allows only certain substances to enter into the CNS. By restricting the entry of substances, it is basically protecting the brain from harmful toxins and pathogens. Okay. At the same time, it allows essential nutrients to pass through it. Now, what are all the substances to which it is highly permeable, to which it is impermeable, and it is moderately permeable? That is also an important MCQ. You see here, highly permeable to water, any lipid soluble substances like gases and lipophilic substances like free forms of steroid hormone, alcohol, and anesthetic agents. So it is highly permeable to water, gases, and lipid soluble substances. Slightly permeable to electrolytes like sodium, potassium chloride. It is slightly permeable to electrolytes. Totally impermeable to plasma proteins and protein bound forms of steroid hormones, protein antibodies, and most non lipid soluble large organic molecules. So, basically, all proteins and polypeptides cannot enter the blood brain barrier. Lipid soluble substances, gases, and water can easily enter the blood brain barrier. Important vital nutrients and electrolytes have moderate permeability. Okay. Now, as I already told you, in pathological conditions, the blood-brain barrier is compromised. What are the functions of the blood-brain barrier? One is protects the brain by selectively allowing certain substances, and at the same time, it also prevents the escape of neurotransmitter and maintains the ionic constancy in the brain fluids. So that is with the structure function of blood-brain barrier. Now let us look at the options. What they are asking is, among these four options, which of the following statement best describes the role of blood-brain barrier in the given subject? Okay, so the blood-brain barrier prevents all therapeutic drugs from entering the central nervous system. Is it true? No. The blood-brain barrier is primarily composed of astrocytic end feet that restricts drug diffusion, but it also involves the uh, not only astrocytes but also the endothelial cells of the capillary. So even that is not the right option for the given pathology. The blood-brain barrier can be disrupted by inflammation, allowing larger molecules and contrast agents to cross. Yes, this is the answer. Let us look at the last option. The blood-brain barrier exclusively regulates the passage of ions and does not affect the permeability of larger molecules. No. Okay, so what is the right answer? Option C. Now we have another question. A 53-year-old patient presents with difficulty. A 52-year-old patient presents with difficulty in planning and organizing tasks. So it's a CNS disorder. The patient has problem with planning and organizing task. So planning, organizing tasks, these are all called as executive functions. Okay, these are executive functions. So the executive function is lost. Alongside, the patient is also having personality and social behavior issues also. Neuroimaging reveals atrophy in the frontal and temporal lobes. Okay, executive function is actually the function of the frontal and temporal lobes. Based on these findings, which of the following cognitive function is most likely impaired in this patient? Which is impaired here? I already told you. The executive function is impaired. Okay, they have given other options as well. After finishing this question, we will take a short break. So the other function, let us look at the other options as well. First option is visual spatial processing. The second is executive function, that is what is lost in this patient. Then we have memory retrieval and then language comprehension. We'll just see which area is responsible for all these functions, and if it is affected, what is the clinical signs and symptoms with which the patient is going to present us with. As I already told you, in this question already they have told us neuroimaging studies have shown atrophy of the frontal and temporal lobes. So when there is atrophy of frontal and temporal lobe, it will lead to frontotemporal dementia. In frontotemporal dementia, the executive function is lost. That is planning, organizing, even personality changes, all this will happen. Okay, so that is what we are seeing here in our patient. Suppose visual spatial processing is lost means how will the patient present to us? They will have difficulty in visual memory and spatial organization, which is mainly the function of the parietal lobe, usually seen in diseases like Alzheimer's disease and stroke. Executive function we already saw is the function of the frontotemporal lobe. Executive functions are lost like planning, judgment, behavior, all these things. What about memory retrieval? Memory retrieval is a function of the hippocampus as well as the temporal lobes. Again, the patient will complain of difficulty in recalling faces, difficulty in recalling events, memory loss will be there, mainly seen in diseases like Alzheimer's and amnesia. Finally, language comprehension is lost means damage should be either due to the Broca's area, Wernicke's areas, all those things we just now discussed, and they are going to have aphasia. Okay, usually seen in stroke or even in Alzheimer's disease.